My name is Bobby Kalantar. I am Chief of the Division of Spine Surgery in the Department of Orthopaedics at MedStar Georgetown University Hospital. The patients I see are people complaining of neck or back pain, sometimes with arm and leg pain, numbness, or tingling. Well, one of the things that opened my eyes to spine surgery was my own experience. When I was 20 years old, I had spine surgery myself. I was having a lot of leg and back pain and subsequently required a fusion. It was a very scary thing for someone my age, but it really did change my life. I was in a lot of pain, and my pain completely went away and allowed me to get back to what I want to do. And I think my experience with spine surgery and the ups and downs of that experience allowed me to really understand the flip side of the coin and what the patient's going to, both what they're scared of, the fear of surgery, and even the simple things that we take for granted in the recovery phase. As physicians, I can see it a little bit more from their point of view. When a patient comes in, even at their first visit with me, it's perhaps the most important thing is that we have to develop a rapport and a relationship. You know, in many ways, sometimes I'm a second or even third opinion for surgery, and it's not an ego battle of who wins out in getting the surgery. It's basically what's the right fit between that patient and the surgeon. And the relationship doesn't start and end with surgery. There's an extensive treatment and setup prior to surgery. We all have to be on the same page, and then there's an extensive follow-up after surgery and rehabilitating the patient. So surgery is only one part of the whole relationship. I try and look at every surgery I do initially through a minimally invasive way, and if I can treat that problem with a less traumatic option, that's the path I want to take the patient. Usually about 80% of the things I do can be treated in that method. As far as being an accomplished minimally invasive surgeon, it does take two things. You need to be trained in it. There is a high learning curve with these procedures, and you really need to be up high in the number of cases that you've done to be able to excel in doing it. And on top of that, you need to be able to incorporate that into a practice and have enough experience over many years of practice to do it efficiently, effectively, and successfully. I do minimally invasive spine surgery in roughly about 80% of the conditions we treat can be candidates for minimally invasive spine surgery. Basically, the idea of that is we can accomplish the goals of any operation, whether it is taking pressure off of a nerve or stabilizing the spine or performing a fusion surgery through a much less traumatic approach, through smaller incisions with less tissue and muscle damage. That allows a huge benefit in pain after surgery. The recoveries are much faster. The hospital stays are much shorter. The risks of infection and blood loss are much lower. Overall, the patients in that period of time do much better than the traditional open surgery that has been offered for years. A common question I get is there a laser in spine surgery? There is a lot of advertising out there, marketing out there for laser spine, and in actuality that is essentially a gimmick. There is no true laser in spine surgery. That is a form of pain management. That is not a surgical procedure typically done by non-surgeons, and really minimally invasive spine surgery is the most minimally aggressive surgery there is. When somebody has a spine condition, a common condition is a herniated disc that can cause arm or leg pain, and the vast majority of these conditions do not need surgery. The vast majority can be treated non-surgically with medication, time, rehabilitation, and only a small percentage subsequently need to have an operation. When those patients that do not respond to non-surgical treatment or are in severe pain from their herniated disc need an operation, that's where I can come in and help. And there are a lot of minimally invasive options to treat those conditions that are highly successful. Stenosis means narrowing around the spinal column, meaning narrowing around the nerves or the spinal cord itself. The vast majority of patients with stenosis do not need surgery unless they are symptomatic from it. And that can show up as weakness in the legs, heaviness in the legs, problems with balance, or clumsiness in the hands. If those symptoms are there, then surgery frequently is needed to alleviate those symptoms. And there are a lot of ways that can be accomplished. There are some minimally invasive techniques for stenosis that can decompress the nerves or the spinal canal and also stabilize the spine. A lot of common questions I get in the office in regards to taking pressure off of the nerves is a fear that it will always need rods and screws and a fusion to come along with it, and that is not the case. With every procedure I do, my first look is to see if I can avoid a fusion, and I would say at least 50% of the time we can. One possible long-term implication of a fusion is what it does to the levels next to your spine. Our techniques are improving and we're minimizing that effect, but if we overload other levels, those levels could potentially cause trouble in the future. We have a much better understanding nowadays of why that happens, and we've been able to minimize that, but we can't remove that risk completely with a fusion. One common question is whether or not loss of motion as a result of the fusion is going to affect their ability to mobilize. And most people, for a 1 or 2 or even 3-level fusion, cannot really notice a significant loss of everyday life range of motion. Once they heal and get back to a full active lifestyle, most people feel that they're moving at the same amount that they were before. The recovery phase from surgery depends on what we're trying to accomplish and if they're getting just a decompression surgery or a minimally invasive disc herniation procedure or a fusion. For a minimally invasive disc herniation procedure, most people can be back to full unlimited lifestyle by 6 weeks after surgery. For a fusion, it depends on what they want to do. The fusion typically can take anywhere between 3 and 6 months to solidify. So as soon as 3 months after a fusion, I will allow patients to really pick up their activity level, sometimes as long as 6 months. A lot of patients ask me, will I be able to return to my full sport level after a fusion? And a perfect example, famous example, is Peyton Manning, who had a 2-level neck fusion and has returned to playing NFL football. There is a safety that's there when we fuse the spine. If it's healed adequately, we can really let you do anything you want. A common question I get is trying to understand why a neurosurgeon and an orthopedic spine surgeon are doing the same surgery. And historically, the neurosurgeons would do more nerve work and the orthopedic surgeons would do more of the bone work. Over the last 10 or 15 years, the training has come together for both in fellowship training, and in both specialties, we're extensively trained in both the bony and nerve work that's required. So nowadays, spine surgeons are essentially a specialty in their own with no real big difference. So immediately after a spine surgery, no matter what kind of surgery, even if it's for a large scoliosis or something like that, I want the patient up and moving immediately. So if the patient requires a hospital stay after surgery, the physical therapists get them up the day of or day after and get them walking. I want all my patients by their 2-week follow-up to see me walking 1 to 2 miles a day. All surgeries nowadays, we're trying to push you to get up and get moving and get back to an active lifestyle. To help the muscle recovery. So it's very important to return to an active lifestyle so that our muscles come along with the nerves and the bone that we've fixed in spine surgery. We need to keep those muscles moving, keep them strong. We need to encourage those nerves to recover faster. In the vast majority of surgeries, you do not require any more immobilization or bracing after surgery, both for neck and low back operations. Very rarely in patients with very specific diagnoses do they need a brace. Yes, if unnecessary, a brace can sometimes do more damage than good. In the end, we're not just a skeleton walking around. We have a bunch of muscle moving that skeleton around, and if we weaken that muscle, much like a cast will atrophy muscle around bone, then we're going to probably have persistent symptoms longer. So I encourage the patient really to not immobilize themselves too much, to be out of a brace as much as possible and get those muscles to come along with the rest of the recovery. MedStar Georgetown, top down, is very experienced from the simple to complex spine condition. We're fellowship trained with a lot of training experience and surgical experience in practice in dealing with every type of spine condition that walks in the door, even those in which other spine surgeons in the community will refer here to take care of. We know minimally invasive and maximally invasive surgeries, and we need to apply the correct answer for each individual patient's problem. And in doing that, we've been able to really obtain a high success rate. The bloodless surgery program here at MedStar Georgetown Hospital basically utilizes both preoperative and postoperative management in conjunction with intraoperative anesthesia to minimize the need for a postoperative blood transfusion. It allows us to minimize blood loss during surgery and the need to support blood loss after surgery. In the end, bloodless surgery can be very simple. It can be just a monitoring mechanism to make sure what our blood levels are and then incorporating a more simple operation to treat it, versus very complex, where we give preoperative medication to boost blood levels and then use intraoperative techniques such as a cell saver, which is able to cycle the patient's own blood back into their bloodstream to prevent the need for another form of transfusion. Our default surgical technique here at Georgetown, in conjunction with the anesthesiology team, is to practice our bloodless surgery techniques, which minimize blood loss, which already we accomplish with doing a minimally invasive operation, but also minimizes the need for any blood transfusion, even with bigger operations. We look to that method of treatment for all of our patients. In the end, our goals as a surgeon and as a team of physicians and nurses taking care of a patient should be to minimize the overall trauma of that operation on the patient. And that does include the risks of blood loss, bringing your blood levels down to potentially dangerous levels, or needing transfusions to support blood levels. I think as a whole, the whole movement of medicine at the hospital is basically trying to control that aspect for patient care, and all patients, despite religious belief, would be and should be treated the same in that manner, and that's what we're incorporating in our techniques. So a minimally invasive surgery is not shorting the patient on any kind of goal of an operation. It can still accomplish the fusion that an open surgery can accomplish. It can still accomplish the decompression of the nerves that any open surgery can accomplish. It does it less traumatically through smaller incisions, but does require a high level of specialty training and experience in order to perform it safely. Some surgeons have not been trained in that and will offer the traditional open surgeries, which are still yet effective, but do come with the higher risks of blood loss, hospital stay, and infection rate. A minimally invasive operation is available for most spine conditions, and it would be reasonable to get an opinion on whether or not a patient would be a candidate for that.